very high burden of HIV, malaria, tuberculosis, acute respiratory infections, among others. Mortality rates are also significantly high. Artificial intelligence actually provides, and machine learning actually provides enormous opportunities for Africa to improve health indices and also to not only better understand the spread and outbreak of diseases, but to also be able to better control this. At Co-Creation Hub, we are particularly interested in health, and I've set up the Design for Health practice as a way of strategically positioning to support both governments, partners, and individuals in Africa to combat the challenges, public health challenges in Africa. Our goal is basically to intentionally innovate within public health space to address public health challenges on the continent. The Africa Digital Epidemiology and Innovation Network, ADIN, is one of the expressions of the Design for Health practice. Within ADIN, I would say that it's a dynamic Pan-African network. As Adefemi has mentioned, we have researchers, scientists, public health enthusiasts, governments as members of our network, innovators, technologists, and overall public health enthusiasts from across 10 countries in Africa on our network. This network was founded in 2020 during the height of the pandemic. And our mission is really to unite professionals, researchers, enthusiasts with a shared vision of utilizing technology and unconventional data to enhance disease surveillance, prevention, and response. Since 2020 till date, we've collaborated within the network to develop notable, impactful research publications. We've carried out capacity building initiative, hackathons, extensive networking activities as part of the key achievements over the last 3 years. Our pillars are actually knowledge, innovation, and collaboration. We provide a platform that allows people to share in their areas of expertise and comparative advantage within the network, knowledge, innovations, and to collaborate towards the achievement of our goals. Some of the activities that we carry out include collaborative research, innovations showcase, knowledge lab, providing access to authoritative resources, members-only networking activities, hackathons, and we look forward to having our first physical conference in the year 2024. The traditional methods or traditional epidemiological tools are in recent time being significantly complemented by innovations, especially innovations in artificial intelligence and machine learning. We have artificial intelligence-based models and systems can actually improve patterns of recognitions of disease spread in populations and predictions of outbreak in different geographical locations. I would say that the benefits we can harness is significantly enormous. Currently, with the progress of information technology, there has also been an increase in enormous amounts of public health data that are very useful for public health disease surveillance. Data is being generated daily on Internet of Things alongside classical data sets, which can help us better understand the dynamics of infectious disease. System interoperability is also very critical in this age. The ability for one system to speak to another and to draw data from one system to another also increases utility of that data towards the achievement of our goal. Today, I'm glad to have Abiola Ochuni speak to us about a system that has been developed that leverages not only artificial intelligence, but system interoperability in helping to improve surveillance and also early detection of diseases. This is particularly interesting for me and for us at the Design for Health practice, as well as ADIN, as we look forward towards 2024 as a year where we're looking to critically engage in artificial intelligence, machine learning, and to leverage to improve disease surveillance across Africa. We have structured several activities in the year 2024 that will build capacity and drive AI utilization within our network. In addition, we're looking to carry out hackathons and to consolidate our learnings and to encourage discussions and knowledge sharing through a conference that is planned for the year 2024. We are also conducting several researches to review existing early warning systems in Africa and to also consider how artificial intelligence can be utilized to improve such systems. So once again, I would like to seize the opportunity to welcome you on today's speaker series. I look forward to your engagement, discussions, conversations, and feedback, questions and answers at the end of Abiola's sessions today. And I encourage you to take the feedback and learnings from the conversations we have today into your various organizations to consider how best artificial intelligence and system interoperability can also be utilized within the areas where you work to improve not only disease surveillance, but overall improvements in public health. Once again, I welcome you all to this session, and I'll be handing over to Adefemi at this point to take over. Thank you very much for joining.
Thank you very much, Stephanie, for that very heartfelt and then very warm introduction, opening remarks. Thank you very much. That is well noted. And then, right, as Stephanie has rightly said, I mean, we live in a world whereby data has been generated every single day, and we have a large data set, and then there is need for us to move from the traditional technology use to more cross-cutting technologies where we have to start applying machine learning, artificial intelligence, that to, improve the surveillance of diseases across our continent. I mean, thank you very much for that, Stephanie. And so I'll try and repeat this previous instruction I gave. So as a form of introduction, please, for those of us on the call, please feel free to drop your name and then your location where you are joining us from. Drop it in the chat box just for us to get to know you better as we proceed with this conversation. And as my tradition, like I always say, I've traveled far across several rivers, several forests to go and bring us our resource speaker for us today, who's going to be giving us this very great discussion where we'll be able to understand artificial intelligence in relation to public health surveillance across the continent. And then, so as a form of introduction, our guest speaker today is no other person other than Mr. Abiola Oshuniyi. Hi, Mr. Abiola, if you can hear us, please feel free to unmute yourself and say hi.
Hi, Adefemi. Thank you for having me on the call. It's a very privilege to be here, and I look forward to having a great interactive time today. Thank you.
Awesome. Thank you very much, Mr. Abiola. I mean, before Mr. Abiola has the stage, and for him to walk us through our insightful discussion today, but please permit me to please share his biography with us, and just give me a couple of minutes to share my screen, right, so I can walk us through Mr. Abiola Oshuniyi's biography. Okay. Excuse me, please. All right. Please, can you see my screen, please? Okay, great. So, as a form of introduction, Mr. Abiola is a tri-sector serial innovator, futurist strategist with over a decade of experience spanning across financial services, health, international development, public policy, business management, as well as governance. Mr. Abiola Oshuniyi has provided technical advisory and support for projects and programs sponsored by the World Bank, Global Fund, USAID, PACT, SFH, DFID, Bill and Melinda Gates Foundation, Qualcomm Wireless Bridge, BMJ, UK Space Agency, Inmarsat, Project Hope, ACO Associates, Clinton Health Access Initiative. He has led many projects that focus on the multiple aspects of sustainability within the public and private sector, as well as around international development, including at Access Bank, Family Bank Foundation in Kenya, Qualcomm in USA, and then South Africa, as well as with various governments across Nigeria. He was formerly the Director of International Development at Instrat GHS, Head of Growth Public Sector at Ilium Health, Vice President, Growth and Partnership at GRICD, and led Partnership and Growth at Cloud Equipment. He functions as a technical advisor to Tech Expo Africa, Nasarawa State Investment Development Agency, Health Facility Monitoring and Accreditation Agency, NCDC, and Nigeria Sustainability Banking Principle. He also sits on the board of different not-for-profits that provide support for government and private sector on sustainability, health, education, and technology adoption. Mr. Abiola Oshuniyi has led the design and deployment of the largest mobile health solution, leveraging ComCare in Africa between 2015 to 2018. He also led the resolution of the 2016 acute methanol poisoning in Ondo State and developed one of the 3 digital health COVID-19 response success stories globally used by the government of Ogun State. He created a mobile inventory reporting application that supported the Lagos State's Logistics Management Coordination Unit. He has education and training from the UCLA Anderson School of Management, University of Edinburgh, Massachusetts, Institute of Technology, Business School, Netherlands, University of Washington, Lagos Business School, Ladoke Akintola University of Technology, ARC Academy, Harvard Medical School, and International Supply Chain Education Alliance. He is a Project Managers Development Association of Nigeria, PMDAN member. Abiola's vision is to build sustainable global brands of African origin. He is a co-founder of the Bardley Institute, a Pan-African not-for-profit leadership, governance, and strategic development organization that collaborates with private, public, community, and international development organizations to foster conversations and actions with the local context to facilitate development, taking advantage of the rich diversity in Africa for global relevance. Ladies and gentlemen, please welcome with me as our speaker today, Mr. Abiola Oshuniyi. So, before Mr. Abiola Oshuniyi have the floor to walk us through what he has for us today, as a form of quick information, please, if you have any question along the course of the discussion, please feel free, I repeat, feel free to drop your question in the chat box. We will definitely take it up at the end of Mr. Abiola Oshuniyi's session. So on this note, I'll hand over to Mr. Abiola Oshuniyi to walk us through his immense work around artificial intelligence in disease surveillance and early detection. Thank you so much, Mr. Abiola Oshuniyi. Over.
Thank you, Adefemi, and thank you, Stephanie, for having me here. Let me appreciate the entire team and my other colleagues across Africa joining in. I like to usually say that Africa has all the resources it requires to grow, and we really have done what we can looking at the resources that we have. However, there's need to always do more. And I think I would like to say this is more a call for us to do more. I'm excited to be here, and I'll be sharing my thoughts and experiences around the use of artificial intelligence in disease surveillance and early detection. And thank you, Femi, for reading that bio. I think we would have just kept it short in between somewhere. So one of the, whenever I have the privilege of doing this, I just, we'll be running through a simple agenda, why we need advanced surveillance, the role of AI in healthcare, disease surveillance with artificial intelligence, early detection using AI, AI algorithms in disease surveillance, data sources for disease surveillance, AI and infectious disease outbreak, challenges and limitations, and the way forward. Please feel free to chime in at any point. It's both a learning process for both sides of the divide. It's an interaction, like I earlier said. At the end of this, my expectation is that we would have an understanding of how AI is contributing to early detection. First, from a very African perspective, apart from the global perspective, because there is that very important need for us as Africans to always think around how we localize technology, or we bring certain things to our local context. Secondly, is also what the role of AI is in managing disease outbreaks. And one of the biggest conversations around the use of AI has been around, the practicability and ethical considerations. Looking at our context as a continent, we would very much agree that we still have a very fundamentally traditional society. So there are certain things that we want to be able to ensure that we are not misrepresenting, and we're actually providing the right scope in terms of traction. So, in a practice I have, I usually like to start with quotes from the continent. And this quote is more an interesting quote and a charge. It says, "There's no beauty but the beauty of action." And why this is extremely important to me is that every time we speak about Africa, one of the biggest things we always fail to recognize is the fact that many times it's not for our inability to think or our inability to innovate. Sometimes it is our inability to actually act. And when it comes to things of like healthcare, and in this specific context, the convergence of the use of technology and healthcare, particularly around the national health security, particularly around disease surveillance. The conversation is around our willingness to act, and then our ability as a continent, as a people, to actually take the action that is required for us to actually do that. I just want to share a few data facts, and Stephanie had shared an interesting fact at the beginning. As of today, we generate about 328.77 million terabyte data every single day. We're in a time in the world where it's somewhat touch point society, where the amount of data we generate is so much that we somewhat do not realize that almost every aspect of our life or of our lives are already underpinned by significant data that can be used to determine our behavior. Just as an example, a few years ago, probably like 10, 15 years ago, you would remember, and I just wanted to take your mind back, when the earlier runs of Facebook was coming up, and you would probably tag a photo and the photo will not be able to recognize you. Right now, if you literally take a photograph, your mobile phone would recognize you or recognize anybody that you previously has used, or kind of tagged in that photo before. And that's literally just AI working in just photos on your regular phone. Just specifically to our context, specifically to health, it will take 21 hours every single day for a general practitioner to be able to catch up on primary healthcare literature that is generated in the world. It tells you that there's a significant amount of gap in terms of knowledge, in terms of new research, in terms of new findings. And interestingly, we only use 3% of healthcare data that we generate to generate actual insights. And every time we speak about evidence-based decision-making within the healthcare space, one of the biggest things we fail to recognize, particularly on the continent, is not the fact that we don't generate data, is that we are not able to generate insights with that data accurately. Why? Many of our data sets are extremely siloed. So I will use a quick illustration. So let's imagine that whilst you grew up, whilst you were born, you had your birth registration done, which also tied with your parents, essentially. So that's a data set, which is civic registration. Then you went to primary school, got registered in primary school or elementary school. That is also your data. Your attendance in school, your missed days, your performance in school are all data sets. during your immunization process, you had data sets. If I pick all those, look at those data sets right now, all of those data sets sit in separate silos and they don't speak to one another for me to be able to make specific get specific insights about who you are, what you do, and how you do specific things, which is the reason why every time as a practice of a place like Nigeria or other national governments, you see new agencies coming up, around trying to bring some data sets. So in other climes, all those data sets are somewhat interoperable. So essentially, I can define or determine or track or kind of build a trend of who you are, your behavior. And essentially, that's exactly a lot of things also around disease surveillance. Another key data I wanted to share, you probably are seeing it already, is that there are over 42 million medical errors that actually happen every year. Interestingly, when you have medical errors, then you have a higher risk of people actually, you have a higher risk of morbidities and mortalities. And what that essentially means that there are certain things that are preventable. Today, we have a significant emigration from the continent of skill sets, which means you would have more pressure on the population of healthcare workers within the healthcare system. So essentially, that's something of great concern if you look at, and just right there, 163 million people, 163,000 people in Europe. For the lack of data, I was trying to basically look at specifically as attributed to Africa, those that actually die from medical errors. And you very much would agree with me, if we do a deep dive, we'll probably have a significant majority. Just as a background, I just wanted to share that most times when we talk about AI, it seems like it is basically up there in the air. And I started with the concept of the fact that we do have data as a people, but the data is actually sitting in different silos, and those silos are not speaking to one another. So essentially, AI is just about the ability for a computer to think and learn and make smart decisions based on data instructions, just like people learn from their experiences. So one of the biggest things we always say, we say experience is the best teacher. So essentially, thinking about providing experience to a computer, learning from the data you've been providing and the kind of instructions that you're providing to that actually computer. So there's a learning behind it. So think of it as, whether be it machine learning, whether be it neural networks, whether be it natural language programming with, things that we've seen in like the ChatGPT conversation, or in advanced robotics, where you can, or systems automation, where you can do activities and be repeatedly done by the machine, or in this case, by the computer, or by an algorithm that you've created. It then gives you the ability for you to learn and then make decisions fundamentally. Now, the key for artificial intelligence is to be able to say, if I did not have all the resources, if I did not have all the time, and resource here, we think about, in terms of human resources, the time and the financial resources, but I've set up a system that allows me to actually carry out tasks in a short, easy way. It then means I can actually get results faster. So I'm making all of this background specifically because when you begin to go into aspects of disease surveillance, you begin to see specific things that are quite interesting. So fundamentally, today, disease surveillance is literally the cornerstone for public health. Every time you go into public health or you go to public health practice, you find out that one of the key aspects around public health or public health intervention is around disease surveillance. And I will show you something that Africa perfected around contact tracing and was very phenomenal during COVID. However, one key thing is anytime you think about public health, you're thinking about the reduction, the identification, and the reduction in the prevention in the spread of diseases. You're basically building a program strategy or approach that allows you to identify, or in this case, detect, allows you to treat or manage, and allows you to actually mitigate the impact of that disease in this case, so that it doesn't either become a significant economic burden. Now, every time you think about public health, I want to just chip something behind your mind. There's an economic cost to actually not having a proper public health framework. So I'll use a typical example. If you had a public health event such as maybe an outbreak of cholera, the outbreak of cholera has been preceded by certain factors that are both environmental, behavioral, and social. So people would have started dumping refugees. There's people may not have been, doing proper hand washing. Quite a number of behavioral things. Pathogens getting into water sources, and then people drinking such water sources or consuming such food, and then getting infected with cholera, and then it becoming widespread, right? So most times when we think about public health intervention, so think about it, every family that was involved or had a spate of the cholera it means that they would not have any economic activity going on at that point. Now, considering that we're a continent that has a significant population living at below $2 level, it means if there's a cholera outbreak, just as the example as I made, people would, and we already know a significant population of the continent also is not covered by any form of health insurance. It means that there's going to be significant catastrophic out-of-pocket expenditure before you even discover that it is an outbreak. When it's discovered that it's an outbreak, maybe, and in most cases, government will come in and then treatment to become somewhat free. So, but the early cases, of course, are usually not free. They would have actually paid out of pocket because they would have gone to the hospital or their local pharmacy to kind of get some form of commodity or drugs to treat themselves. And in a place where, or on a continent like Africa, where cost of healthcare is still significantly high, there's significant, and we'll talk about that in a bit, there's significantly suboptimal funding into healthcare. The early detection of any outbreak is significant. It's very important. It's very strategic, because once you move an outbreak and it reaches its peak, you are left to the what you would call the whims of what the pathogen is like. The dynamics of it could change. I don't think anybody in the world expected that the world would be able to close with the COVID for almost over a year, and you still have feedbacks from that singular event, and that's still a public health event in itself. So that's exactly how an outbreak can be. It could be mild, it could just phase out in a pattern of days, and it could take weeks, it could take months. And in this case, like we've seen with COVID, it took significant amount of time. One key thing, like I've kind of alluded to, is that the fact that public health is not just interested in saving lives, using disease surveillance as a tool, but is also specifically trying to reduce the economic and social impact of diseases. So today, we also still recognize that specific diseases, are stigmatized, right? So you want to be able to capture those things quite early, manage them, and then create the right corrective actions. So essentially, disease surveillance looks at early detection of outbreak, timely response to threats, and the prevention of the threats of those diseases as a major highlight. And why it matters is that it is often key to preventing localized outbreak before they become global pandemics. Those are two key things. Why is early detection very important? The difference in any outbreak would be how the outbreak response actually happens. And if the outbreak response is quick, prompt, you would be able to get good feedback. Why is, and I just wanted to kind of share this ahead before I go into deeper context. Why is there need for advanced surveillance, and what we look at the challenges for traditional disease surveillance methodology? Traditional disease surveillance methodology has a process where there is a lag in terms of time before a real response happens. So when there's an outbreak, when there's a public health event, what would happen is the index case will probably have to show up at a healthcare facility, or some morbidity or mortality would have to be recorded in a healthcare facility. And you must see a number of cases to actually flag that that is an outbreak. Essentially, remember, one key thing is that our public health system across Africa is still fundamentally paper-based. We do have a bit of technology into it, but we're still primarily paper-based. So a healthcare worker still needs to record that data at the healthcare facility, send to their disease surveillance notification officer. The disease surveillance notification officer transmit that information IRO, and that process then escalates before you get, a sort of, let's call it a national response or regional response, as the case may be. So it kind of tells you also, in terms of data visibility, there's limited visibility. Yeah, quite interestingly, there are quite a number of digital solutions that have been, both government-led, partner-led, and private sector-led across the continent, but we still have limited data visibility. Like I explained at the beginning, the convergence of data from your attendance of or absenteeism from school, the consumption or the buying pattern of commodities at the PBMVs or local pharmacies, the kind of tests done at labs, plus the kind of data that is coming from hospitals can actually be overlaid to even get, to check whether public health events are happening in the background. And for every public health event, there's usually a spike. So that limited visibility always creates some process. So in terms, there's also the fact that there is that geographical and temporal limitation with traditional epidemiology or traditional surveillance. So people move from location 1 to location 2. So yeah, I wanted to share a map that was designed by IOM and how they do a bit of their response during migration. So a person can actually have a disease or an infection, and the person can move across border and go to another country, go to another state, go to another region, and it can potentially spread. However, because the data from the two regions do not speak to one another, you would not really notice that there's been some movement. It will take some time, which is the conversation around time and limited data visibility. So there is some form of geographic and temporal limitation. You won't see when the index case is. By the time you see it, there's been some progression in time, and there is the factor of, we do have significantly limited resources. And in this case, limited resources speaks to our policies as a continent actually embraces the use of technology, but does not essentially create a easy pathway for people to adopt the use of technology. What do I mean by that? So you will see that within the African system, there are quite a lot of conversation around the use of technology from improving things like data governance, healthcare governance. But when you go to ministry, departments, and agencies, and you check the capacity of persons that are actually able to engage the systems, you then begin to understand that even if you put the best infrastructure in place, there's still going to be a significant gap in terms of challenge of using it. Of course, with infrastructure comes the use of the conversation around costs, right? So that's a big issue as well when we begin to think about, surveillance, and of course, human resource itself. I'm apologetically Nigerian and African, and we all know that there's something we call the Japa syndrome from Lagos. For those that don't know, essentially it means people are migrating out of the continent. So that's a human resource issue. So essentially people are leaving. And so if you were going to look at the way responses were before, you probably say, oh, we will use our team of community health extension workers. We'll use our team of nurses. We'll use our team of doctors. If you check progressively from between 2010 and 2022 until date, you would have seen progressive reduction of the workforce across Africa, especially health workforce, considering quite a number of people are actually leaving the continent for better opportunities. I just wanted to, because I have a background in urban planning, and I just wanted to kind of set this concept for us. Every time we speak about surveillance, essentially surveillance is mapping. And I've had very interesting arguments with plenty of people around the fact that urban planning and public health, have some very strong relational processes. So, and John Snow happens to be, interestingly, an urban planner and a public health person simultaneously. So essentially, it actually resolves that conversation. And, this 1854 map was one of the very first attempts at actually mapping the incidence of cholera or any public health event. And essentially, this provides what we call the modern conversation around epidemiology. So epidemiology is just, let's just call it disease mapping. Let's just call it public health events mapping, fundamentally. Let's say epidemiology or traditional surveillance helps us to understand the processes behind how the dynamics and trends around diseases in locations and how it allows us to be able to make the right decisions. One other key thing about that process of mapping is essentially using what's called a contact tracing process that allows you to be able to, once a case is identified, once you understand what kind of disease it is, based off of the case definition of the disease, you're then able to say, we need to be able to identify persons that have come in contact that may be susceptible to this particular disease as a reason of the kind of contact, and then begin to check, based off of each of those diseases, what their incubation periods are, and then check, and track all of those events. Africa did significantly well during COVID because, we've kind of built, based off of our polio eradication programs across the continent, a strong methodology of contact tracing, door-to-door search, and our immunization process as well. A strong case of door-to-door searches around contact tracing. So, contact tracing is a key component of surveillance. And interestingly, if you notice what I mentioned, this is still fundamentally sort of manual, sort of not digitized, right? Except for certain parts of it that are getting digitized within the last 5 to 10 years, which is the reporting aspect of it. One key thing that the contact tracing process or epidemiology generates is usually the epidemiological curve. And that epidemiological curve speaks to the number of cases over time. And the key for any epidemiological response is to actually, if you're looking at the screen, you will find out that there are two peaks here. You'll find out that there's a lower peak and there's a higher peak. The idea is to ensure that you do not allow the cases to peak beyond a point where the risks are a lot higher. So you want to delay the peak of the outbreak, so that there is limited, reduced risk. You are mitigating the risk of people getting more infection. What does that mean? So, the moment you pick an outbreak early, you are able to quickly respond, track all the contacts. If you need to quarantine, you quarantine. And why is this extremely important? For all the public health events I've always been around, I've always been part of, one key thing is there's usually a requirement for the consolidation of resources, which is usually very difficult if you have an outbreak that is not responded quickly to, because what would essentially happen is that you have more mortalities or morbidities. And once you're having more mortalities or morbidities, other than the fact that you risk the idea of misinformation amongst people and disinformation, there's also the significant amount of resources that you now require to respond to that public health event. So if you had an outbreak that was limited initially in scope and geography and time, it's easier for you to say, and I'll use the concept of cholera again. So cholera happens in a city X, and the same city is on the same river line or same pipeline as city Y, Z, and J, right? If I stop the cholera outbreak in city X, I am able to manage the amount of cost of my response, if rather than slowly just responding to it, right? So there's usually that conversation around how you respond to, and in many for many outbreaks, some of the reasons why you find that outbreaks responses are usually so slow is essentially as a result of governance issues, right? In terms of how the administrative processes are essentially done, and how the public health identification first, the detection process is actually happening, and then the size of or the strength of the healthcare system itself. That's how all of those things come to play for you to be able to really. So when you see that in certain communities or in certain societies or in certain countries, when there's an outbreak, it takes a longer time. One, that's a resource issue, and that's a governance issue. Two, then the health system is not as strong enough as to deal with that outbreak, which then brings in issues relating to healthcare resilience and healthcare system strengthening. But despite the ills, and I'm trying to balance the two sides here, there's been significant progress on the continent. There's something called the integrated disease surveillance and response approach, which was introduced by WHO through the WHO Afro, where there are priority diseases that we report, and it allows us to capture those priority diseases, and also then uses a methodology of assigning roles in terms of communication coordination across the continent. There are currently about 42, 43 priority diseases. And all of them focus on, some of them are categorized that you must report immediately. Some you can report within the 5 days. Some you can report subsequently after. But one interesting thing I like to talk about is that between 2017 and 2019, just before the COVID, and COVID kind of makes everybody feel that there was not so much being done on the continent. There's been significant time in terms of the reduction of outbreak detection, on the continent. So it had moved in 2017 from 14 days to a 4-day period, essentially saying that the IDSR process was extremely successful and was getting better. And this is also connected to the follow-up, like I said here, of an approach called the 717 approach. Essentially, the 717 approach is a strategy that was also adopted, and Nigeria and in all of countries on the continent are within the 717 alliance, that looks at, when the moment an outbreak emerges, you must be able to detect that outbreak within the first 7 days of it, make a notification within a day, and ensure that response to that outbreak is actually initiated within the next 7 days. That approach essentially guides conversations around resource mobilization, resource governance, and allows governments, allows the public sector to be able to quickly respond to public health events, as the case may be. Just for context, and thank you, Stephanie, when you spoke earlier, there are certain things you shared in terms of what the healthcare landscape of Africa is about. And one of these things that is key for us to consider every time we're talking about the use of technology, we need to understand our context and our issues. So right now, we've spent a lot of time speaking about the gaps in our staffing, gaps in our infrastructure, the gaps in the fact that in terms of, IPs for the manufacture of commodities also is limited on the continent. I wouldn't say it's not there. I wouldn't say it's inadequate. It's limited on the continent. There are other things around, the high burden of infectious diseases. We're still battling with malaria. Significantly, a lot of the deaths on the continent are still connected to malaria, HIV, tuberculosis. We still have a high maternal mortality rate, which is still a major concern. We still have significant health inequalities on the continent as well. While we still are battling and have made progress in our surveillance, it is still having certain aspects of it as inadequate. And that those are some of the reasons why, technology provides a fundamental framework that we can leverage to actually achieve better traction. But more importantly, and this is one of the things I started with, our health information system is fundamentally fragmented. So you are not able to make complete decision, a holistic decision, a better decision. At the beginning, I said that AI essentially is providing data to a machine system for it to learn about processes and then make better decisions. So essentially, if I give it limited data, it would only make data available or insights based off of the amount of data I've given it. So that is something for us to begin to reflect in terms of our data interoperability, data governance conversations on the continent, where I should be able to provide better connections across data sets so that can be used. So your social data, your health data, your even mobility data, which is already being collected, by the way, by the technology providers and your telecoms providers, can all be connected to be able to make better decisions, especially when it comes to surveillance in this regard. And just for us to get a magnitude in terms of context, it would actually cost the continent, between 2.5 to 3 dollars per annum to achieve infectious disease outbreak preparedness for the entire region. So it is not for the size of the cost, it is actually just our commitment to actually achieving this. And the more we build a strong health security approach on the continent, the better for us. The myriad of our issues are just what this slide is talking about, and basically all the things that limit us. But first off is the fact that as much as our population is rapidly growing, which is the first point, and we're having issues with the adoption of real technology because of our biases, our population is fundamentally a youth population, which means we have the potential of adopting technology in such a way as most other continents may not be able to. And we can see how that has been replicated or that has been demonstrated within the fintech ecosystem, where, as of today, Nigeria is one of the countries where you can actually say, I make a payment transaction now, and as much as possible within the next 1 to 3 seconds, I get that transaction. So think of that process as how I can actually get disease notification about a public health event. And that will go across at the facility level, the regional level, or sub-regional level, to the national level, and potentially to the continental level, because we are talking about interborder movement or migration as well, because essentially, once you begin to think about people moving across borders, then you're thinking about the idea that things can be actually continental wide, as the case may be. So with all this in background, I wanted to kind of create a poser. Let's just for 1 second imagine that COVID-19 happened in year 2020. How would it have been? How do you think, in the comments, you can just share your thoughts. How do you think, what the magnitude you felt that COVID-19 would have had if it had happened in 2020, where we had limited internet access? What do you think? How do you think the world would have looked differently? And you can share in the comments your thoughts around how that would look like. And I had to reflect myself, because there was a remarkable difference in terms of what was happening in year 2020, and we can even just go back to as closer as 2005 or 2010. How do we see differently that the world would have been? At that point, Facebook was still somewhat maturing. WhatsApp was still fundamentally not as adopted as it is right now. So there are quite a number of things that were significantly different. I'm sure that many of us have forgotten that we could not do direct debits from our accounts, and we couldn't do direct transactions from our banks. we were still carrying ledger to ledger. It's quite an interesting world. The M-Pesa in East Africa had not literally taken hold, and it's quite interesting. Let's just reflect. Well, how do you think the world would have been if COVID had happened in 2020? So, while you're responding to the comments, I just wanted you to see what the difference was. And, I'm making all of these backgrounds for you to see why digital epidemiology is something, the same we have adopted the fintech solution, that Africa needs to fundamentally adopt digital epidemiology and incorporate AI into the process. So something that made it very different in 2020, when COVID happened, 2019, 2020, when COVID happened, was essentially the plethora of digital technology that was available. And I'll share a personal experience, and you have it on the screen. You can kind of look at some of the technologies that were used. So when COVID hit, one of the things that had happened was one of the states that I was working with through an organization I was leading, had the issue, one of the very, very first cases of COVID. And one of the very first problems they had was they lacked the resources to be able to potentially start doing contact tracing across the entire state. And they wanted to be able to see instant visibility across the entire state when the data was actually collected. So very simply, what did I do? Once I heard about it, I said, you know what? We can actually use simple touch technology that allows us to be able to embed case definition. And once we're able to define the cases, it then sort of triages each person that were capturing their data to see the risk factor of whether they actually potentially have COVID. Just like any kind of public health event or infectious disease process, you definitely first find out whether this is a suspected case or a probable case, as the case may be. So essentially, build that into a simple application. Deploy that application, build that application in less than actually. I heard about the events at 11 p.m. at night. Build that application by 2 a.m. Sent out that application to my colleagues in the States. They literally deployed it across the state by 7 a.m. And by 12, we already had data across the entire state, and we had a map, and data was coming in real time of, as patients, as people, as active case searches were going on. The entire solution had the capability for letting us know those public health events, those suspected cases, those that they need to do additional contact tracing for, and everybody was speaking to one another without physically being connected, essentially. So, as the data was coming in, it was just fed into a dashboard, and the EOC and, was able to actually have access to that data and then make decisions from the EOC directly in terms of the process, right? Those are early, very simple use of, integration of the learning of case definitions to be able to identify cases, which is just, very simple AI utilization in that pattern. And once we were able to automatically determine what the potential cases were, there were certain quantifications that was needed, commodities, consumables, and all of those things. The system instantly started providing matrices of, predictions in terms of consumable needs that were required, that the government was then able to say, okay, so our estimates were this. So it was more decision-based, it was data-driven, rather than what we would usually have as guesstimates. And this is just 20 years after, if it was COVID happening in year 2000, right? So without visualizations, without ability for us to have mobile phones, for us to have the ability to use simple frameworks, both SMS controlled messaging, at the same time, the app that was developed, it would have been extremely difficult for that kind of feat to have actually been achieved. And while that was being built, I didn't even notice anybody was actually tracking the process. And, later it was identified as one of the most successful quick deployments of mobile applications across the world in response to COVID by ICT for development, as the case may be. So, so essentially the availability of these data solutions, the availability of these digital solutions, digital technologies, already provided a different way. I remember an early paper that I wrote around the use of social listening, what we call social listening in Haiti, for actually mapping the movement of epidemics, which essentially was using both Twitter back then that has become X, and also using SMS and Facebook messaging, right? We're still not as advanced in a lot of societies. We still kind of trying to struggle with that, because what usually happens is that once public health events are happening, people start to chatter about it on their usual channels. And what you want to quickly do is be able to pick those spikes. Of course, you would have public health events that are false positives, but that is where you'll be able to then do an active case search, or you send teams out, and then you are able to then minimize in terms of the cost of the response, because the key thing is, remember, we're trying to reduce the cost, the impact in terms of costs, in terms of social as well, of a public health event. Those are two key things. So based off of this background, that I've just shared, it is inevitable for us to see that just moving on from what has happened during COVID, and I'll be sharing some case studies that I shared, like the one for COVID, and similarly for I'll be sharing some case studies that on this process during this conversation. AI can provide immediate insight for immediate, and that's the key word, immediate insights for emerging health threats. It's immediate. You're seeing real-time monitoring. You are seeing direct end-to-end visibility. One of the biggest things about supply chain is when I lack end-to-end visibility, and my control tower does not have all the data sets I need, I might potentially make mistakes. And those mistakes, as much as you may have margins of errors, in certain instances, those margins of errors can be catastrophic. So, for instance, if I've done an estimate that an epidemic based off of the pattern I've been seeing manually, because I'm not considering the overall data set, is going to just take 2,000 events, or averagely 2,000 events, and I do a costing and I say, okay, let me just put by a value of just additional 500 if there's going to be any variation. And just because I don't have all of the data sets, maybe in the neighboring communities, there are actually 5,000 of those events that were never reported, or that were not actually appropriately logged, or the data set was not linked to me. It then means if any of those population move at any point into my own region, I would have a spike, and I'm already not prepared for it. So automatically there's going to be a disaster. There's a concept of data diversification. You capture comprehensive data. Like I said, today, a lot of people, other than wearables, when people talk about wearables, we look at the iPhone users, but our mobile phones itself is already capturing, like I said, our movement patterns, our use patterns, the sites we look at. It's already capturing a lot of data about us. Of course, and we'll talk about that, issues around ethical considerations to access to data privacy, our social media utilization, and of course, environmental data. That's very key. The environment is the bedrock of so many things that move around us. The environment fundamentally hosts us. So once I have understand the pattern of the environment, for instance, it helps me. So for instance, I function in sustainability as well. And one of the key things that has been a big global concern that had also a public health concern is the issue of climate change. So essentially, temperatures are rising. So public health events that you probably did not have before have already begun to happen, because the environment is creating incubation points for diseases that were either eradicated or that you felt that you had overcome from a public health perspective, and some of them are reoccurring. There's also the social perspective of people, where people have significant vaccine hesitancy, which then allows for resurgence in certain instances. And then, of course, the kind of food and nutrition patterns of people have also changed, which essentially also modifies people's genetic formations, and then also talks to whether people have better defense mechanisms for diseases in their body. So those kind of things all come to play. And with all of this, with the amount of data you have, you're able to then make specific predictive analytics to say, is this going to happen? What are the probability of this happening? But more importantly, is the fact around, cost effectiveness, efficiency. Efficiency speaks to time, effectiveness speaks to coverage. How can I use my $200 to cover as much places as possible, especially as we're speaking about limited resources and universal healthcare coverage and access to quality health? And so those are key things, right? That, AI and advanced surveillance provides for us, in this particular process. So essentially, it has become more apparent that with the face of emerging diseases globally, that there is that direction for us to move into it. We're already seeing AI being used within health for AI in healthcare transformation. There's something called digital transformation in healthcare, where health organizations are becoming more digitized, but don't just digitization from the sake of digitization. Is essentially digitization to provide better health outcomes. So you're getting access to better data analysis. You're getting better access to more diagnosis. You're getting better. Once you have better diagnosis and data analysis, you're getting better access to more drug discovery. There is the conversation around precision medicine, remote patient management, efficiency and precision in terms of kind of medicine you're providing for people. There is that patient-centric care. I'm a very big advocate of patient-centric care. I remember something a while back on a virtual training we were doing for frontline health workers across Africa that was talking about respectful, care for patients. Essentially, that's a patient-centered care approach that allows you as a healthcare or frontline person to provide strong experiences, better experiences for people to actually come back into the healthcare system and respect the healthcare system. And then there's enhanced decision support. Then, of course, because AI is constantly learning. Remember, it's about consistently learning and continuously learning to give better results, better decision. So there's that ongoing innovation, ongoing thinking, constant emerging thoughts, constant emerging approaches. And of course, we've talked about this, and this is probably one of the biggest things for Africa, which is around the issue of the cost reduction benefits, because every time we talk about this, there's a cost reduction benefit. And I just wanted to pick a few things, in terms of application before I go down further. In terms of when you look at the data analysis, and I will speak to that in a later example. A few years ago, we were trying to build an early warning disease system, and the early warning disease system essentially was looking at how do you look at the priority diseases, the 42+1 priority diseases, and then be able to determine how those 42+1 diseases, once there is an issue with them, once there is a spike, instant spike from routine data, you are able to capture it and send an alert to be able to notify the right person across the value chain. And then there is now the right response in terms of going to confirm if this is a probable case of an outbreak, and then quickly responding rather than waiting for when the outbreak has almost hit its peak before you actually capture the entire process. So and this is way before the continent signed up for the 717 approach. And what we essentially did, remember, one of the first things I said was AI is fundamentally bringing data, into a learning algorithm that allows you to be able to make specific decisions. So it learns. So we looked at over 20 years data that, so this was basically scrubbing all the paper-based data, and which is quite unfortunate still on the continent. At that time, we had to look at over 20 years of data across all the different diseases. Some data we were able to get because of the reporting forms that were provided. Some data we're able to get because of the DHIS, National Health Information Management system. Some data we're able to get from consumption pattern of commodities. Some data we had to actually go into the healthcare facility to actually open case files and be able to pull out the data set. Now, once that was done, what it did was we were able to then build a specific model and create specific thresholds. And those thresholds allowed us to be able to understand what the level of data could be. So if, for instance, you have a case where there was a spike. So for instance, once you begin to see, let's imagine 5 cases of cholera in a community, then there's a cholera outbreak. I'm using that example. So once you get into a third case, for instance, then the alert is sent that you have a probable case of cholera in this environment. So it creates a real-time data because now the data already has understanding that once you have this pattern and you break from the pattern, there's actually already a problem with regards to that. So it's triggers alerts, and those alerts are able to be seen in a real-time map, right? So you're not just providing data in terms of physical data for people to be able to see, you're also providing exactly pinpointing the data with georeferences, which is very important. I kind of mentioned earlier that I have a background in urban planning, and GIS is something significant. Georeference data is so rich data that allows you to understand so many dynamics around a particular environment. So, at that point, it changes the narrative from just having 25 people died, 25 people died in local government, 25 people died in a municipality, but 25 people died in a municipality in location Y beside this location. It helps you to understand all of those conversations. So in terms of real-time data analysis, and that example was speaking to the conversation around the application of AI within surveillance. It's the conversation around real-time data analysis because you've already trained the system. So once the routine data is entering into the system is able to understand quickly and give you specific prompts to be able to know, do we potentially have an outbreak? Of course, predictive modeling then goes a little further, where based off of a pattern, predictive models allow you to anticipate outbreaks. Essentially, based off of the sequence or time series that has been happening, the data then looks at it and says, of course, because of how public health events have happened in Nigeria, there's already a sort of circle, outbreak circle that is, and across Africa as well. There's sort of an outbreak circle that we sort of have. But in this case, based off of routine data, the difference would be not just the outbreak circle, it will potentially predict the size of the epidemic that may potentially happen. So which actually helps you in terms of preparedness and response. So you know the kind of resources that you need to be able to allocate. And if it's something that is beyond your present resource capacity, you are able to then start making allocations or preparations to respond to it. So essentially, you are able to use technology in this regard alongside data that you have already generated routinely over time to be able to make evidence-based decisions. So it will be difficult, and I'll use a typical example. I remember one of the projects I worked on with a state, with 3 states, one in Nigeria and one outside Nigeria. And because of confidentiality, I won't want to mention those states. And the head of health departments for each of the states and regions had to have conversations around their budgeting around specific commodities. And one of the commodities was for malaria. Now, the conversation was, how are you budgeting for this particular commodity? In one case, it was the commissioner for health to the governor, and that's a Nigerian case, one of the Nigerian cases. And the commissioner just said, "Oh," and I'll use not the exact example. "Oh, we budgeted 5 million naira, or we budgeted $50,000 last year for malaria commodities. So this year, because we're just estimating that it should go at probably 5 or 10% increase, we'll be budgeting, $60,000 for it." And the governor just said, "Provide me the data evidence to be able to allow me to do that." So in many cases, you find out that even the benchmark data is wrong. So essentially, with a predictive model, you have evidence to actually engage with, decision makers. And in many cases, the reason the decision makers are not able to provide the right resources, and this speaks to the idea of why AI also helps. It provides that evidence to actually engage the policymaker with specific data sets that you can then use to create the right policy brief, the right advocacy for them to actually engage. And then because it's around data that is from different sources, there's that integration across multiple sources. Today we have multiple electronic health record or point of service solutions, touch point solutions, and all of those solutions can come together to provide the data. That allows us to be more holistic, more integrated, and better reach in terms of response. And of course, we talked about this, early alert systems. I don't think we should really talk about this too much. Talk about, proactive preparedness, cost effectiveness. And these are three different examples. The last example I would like to talk about essentially around the EWOS, the early disease warning system, which while Femi was introducing me earlier, he spoke about. So in 2015, and this is me skipping because of time, in 2015, one of the things that happened while working with the Ondo State government, Ondo State is Southwest Nigeria, there was news in the media there was feelers in the media that an event had happened, a traditional event had happened, and a few boys or a few youths had broken into a shrine and stolen some artifacts, and they were going to sell it. And then the event that happened after was that one or two of them had died. However, disease surveillance or science does not base on just emotions, or you want to be able to actually provide evidence for it. While that may be true, right? No doubt about that. But you want to be able to scientifically prove that it is correct. So essentially, a team went to the community. It was really back then, and tried to search. Really is one of those communities that is riverine, and as a culture, the people actually brewed ethanol. They called it ogogoro locally. So they had their own. In Kenya, I know there's local brew called Muratini or something similar to that. Essentially, they brewed their own alcohol. But unfortunately, this alcohol had now had methanol contamination. So it's local gin. It had now had methanol contamination. So which essentially created a sort of acute methanol poisoning within the community. Now, once the news had come up, one of the very first things based off of understanding social media and skill sets was essentially to quickly set up a system that does social listening. I'd already explained to you that I built experience trying to capture what was going on. So on social media, based off of learnings from an event that happened in Haiti using Twitter. So I basically set up that framework instantly to understand what really was going on. And based off of that, it was already obvious that first there was disinformation and misinformation. But more importantly, it was very clear that there was truly an event, and the first set of age brackets were youths, and they were predominantly men, right? So there was already some sort of data being collected based off of that aspect. So it was easy. So we pulled, the EOC was set up. That's the State Emergency Operations Center for the particular event. I was pulled into that EOC, of course, to provide data support and strategy advice with respect to how data will be collected across the process. So very simple. Built a simple data collection app. The real focus is epidemic response. First off, usually was paper-based, and we wanted to change that narrative quickly because it was something we wanted to act fast on. Build a simple data app, collect data solution, shared that data solution remotely. That was just an SMS, actually got everybody in the field. Remember, I said they had already been dispatched to the field earlier. Once the team got the data solution, what they essentially did was capture, based off of the case definition, to identify what the patterns were. Now, based off of the patterns that were coming, behind it, there was an algorithm that were built that allowed us to understand probable cases based off on signs and symptoms. And what the algorithm made us begin to understand is that this case is a probable case of methanol poisoning or acute methanol poisoning, as the case may be. And, first, I must also provide to you as background, I do not have a medical background. So essentially thinking about it, right, I relied on expert knowledge based off of different technology solutions, based off of expert capacity, and built that into a simple algorithm. That algorithm helped to identify that this was a probable case of acute methanol poisoning. Now, working with the WHO team and everybody in the EOC, there were even conversations around that it was herbicide poisoning and things like that, but all of those were dispelled because of there was data set, essentially. So it meant we would have been chasing, we would have been turning ourselves in multiple directions before we eventually would have come back with this. At that point, samples were not yet identified because we were not even sure what it was, right? But with the data, it was very evident that this was a probable case of acute methanol poisoning. Now, with that case, what then happened? The approach just simply changed. From contact tracing to line listing to the entire process of data capture, because it was digitally based, I just revamped the entire digital solution, sent it back to the team in the field, the surveillance team in the field, and they updated their solution, started capturing data. And once they started capturing data, we were able to actually build a trend other than the case that had gone to the facility that we had already seen some mortality. We were able to capture other data sets of people that were already experiencing specific morbidity, right? So at that point, it created, a clear map of what was going on, how it was going on, and where it was going on. So essentially, we were able to see the corridor of the community and the corridor of the state at that time that had the poisoning actually happened. So it was easy for the government from a public health perspective to, run interventions, but more importantly, to run campaigns where people were requested to decant their local genes, essentially, because it now had acute methanol poisoning. So you knew the specific chiefs to speak with because you knew the community you were dealing with, so which made the cost manageable, right? Now, in a space of less than 2 days from the information to the 5th day, it was easy for us to capture specifically and confirm from laboratory tests that this was acute poisoning in less than 5 days, in about 5 days. And once that was done, it was we'd already had it as suspected. We now have it at laboratory confirmed. It was easy for us to pick up all the samples from blood samples of quite a number of the people to be able to then say, oh, this was actually a confirmed case. So it reduced the entire cost. Now, and I'll share with you a similar experience that happened in Rivers State at that time. And compared to Ondo that used a digital system that had AI for early disease warning within it, Ondo had a mortality rate of about 24 persons dying. However, Rivers had 84 people dying just because it was significantly manual based. And I'm giving a practical example so that you get a sense of, just the use of AI in digital surveillance, how it reduces the morbidity and mortality. And the reason why we're able to even further reduce the morbidity, so methanol poisoning can potentially cause blindness. A lot of the gentlemen that had the cases that were found, and many of them were men, like I initially said, it was easy for them to begin to recover their sights because we were able to discover them rather quickly. So imagine that we were still using the traditional method of paper. It meant they would have lost their sight or they would have lost their lives. So essentially, it tells you how easy, and this is a live practical example that I was involved in, in 2015. And you can basically Google the internet and just look at Ash Irili MCG or Ash Irili outbreak. And you will see some of the conversations around that, and you can just kind of read about it. A lot of people wrote different things. So, from a disease surveillance conversation, or from generally an AI conversation, there are conversations around machine learning in terms of the technologies that can be used to extract insights. There's AI also uses what you call deep learning, NLP, natural learning processing, where one of the interesting learning processes that is conversational AI. I was speaking with somebody recently, and we're talking about how I can use conversations to be able to actually, detect certain things. There's a solution that I came across in early days. It was called Obenwa. Obenwa, and I think it was even hosted by CCO. Obenwa uses the cry of the child to determine specific conditions in the child, and that's just from the cry of the child. So, and those are things that are based off of different levels of data sets to be able to bring meaningful insights that are helping healthcare. And that is fundamentally the base of disease surveillance: clustering algorithms, anomaly detections, and of course trends from time series analysis. I just wanted to just reiterate this because this is extremely important. One of the very big things is every time we speak to AI or use of data, we always look at just health data or certain aspects of health data. Of course, we have EMRs. Of course, we have inventory systems, and inventory systems are just not local to the healthcare facilities. They are also local to the communities, the patent medicine vendors that we use, the social media. We have wearable device. We have environmental sensors. How do we then ensure that all of these kind of sources are integrated? We can have real-time monitoring, and then we can then begin to do a lot of predictive modeling based off of all of these data sets. This is an example of something within the National Health Policy. I was part of this process between 2015 and 2020. It was the National ICT Framework, and it kind of talked about an health information exchange at that time, based off of an interoperable layer, right? So today, there's quite a number of clients that have different kind of HIEs, and those HIEs may or may not have AI. They may just have some decision support in them. But once we integrate AI into them, think around it that the data from my laboratory, my health information exchange conversation, M&E data when people go into the field, when I buy commodities, all of those data sets go into a health information exchange that allows you to be able to crunch data and make predictive analysis or just check in the baseline whether any kind of disease is happening. So it essentially makes disease surveillance cheaper. Honestly, and we all know this, disease surveillance is expensive. It requires rigorous work. Disease response is a lot of work, a lot of resources required. However, once we get the technology bit of it, we are then able to, do rapid responses. We're able to do disease containment quickly. We're able to do medical supplies and healthcare personnel mobilize as where they are needed. We're able to lower economic costs and social disease burden, and we're able to prevent lives, and reduce the escalation of disease threats. I've spoken about this before, in terms of identifying patterns, predicting and reducing the lag time, in terms of early detection. And I kind of made the example of the acute methanol poisoning outbreak that I spoke about earlier as a case note. I wouldn't want to go over that again, but you definitely see the difference in terms of time, in terms of outbreak containment, in terms of outbreak. By 11 days, the outbreak was already contained in Ondo, the example I made earlier. While in Rivers, after 16 days, the outbreak actually fizzled out, essentially. So you can see the difference in the two of them. This was a GIS generated map. This was of what happened back then, and really for you to get a sense of how the data was able to quickly let know exactly where things were happening. The red points here that you see on the screen, where the intersection is to your left, is where the incidents were happening. And it was easy to kind of cut out the entire zone here for the kind of responses that you were given. These are some, just feedback from the system. This was some of the samples we worked on collecting back then. This is a 2015 picture. This picture is pretty old, and these were some of the chatter that were going on the internet with respect to this conversation. So you can go on and check it and see how this is worked. And this is literally way before we had a COVID. Another example of this, is with TB case definition. I wouldn't want to go because of time, but essentially, what this is also doing, similar to what happened with the COVID case, the acute methanol poisoning case, is, one of the biggest issues with TB is when TB is untreated, other than it's deleterious to health, it is catastrophic in terms of cost. It also has higher infectious rate impact. And because it is also an opportunistic infection, people that are already HIV positive or maybe sick from other ailments, you then have cases of people losing their lives, other than the fact that in of itself, TB can actually cause loss of life. So, one of the biggest issues is usually being able to track cases and identify cases of TB. So, of course, just like immunizations that, are sort of being gamed across Africa, whenever you have those kind of issues. But in this case, you are actually using both data that you have cleaned, data from multiple sources to actually determine the specific hotspots for potential TB cases that are then captured, and then tests are done on them, essentially. And this map is also generated from that process, where out of the 14 states where this intervention was going on, it was clear exactly where priorities were supposed to go to, and it showed an increase, identification and diagnosis of additional 10,000 people in the case. And we've talked about the EIDSR. Because of time, I won't go into it. And while these are at the point where the IDSR is, and the DHIS is, they yet don't have, and that was exactly the reason for this particular examples I was going to make. They have data being collected and siloed, but and they have some level of decision matrix. The next conversation for us is, how do we bump this up using artificial intelligence to get us better decision-making pathways? How do we use better AI for micro-planning, for vaccination processes? And this is already happening on the continent as we speak. So, from a challenges and limitations standpoint, because of our time, I just wanted to speak to some key things that people have raised over time, and I see this as key things that we need to then speak about as Africa. There's conversation around issue of data privacy. There's the GDPR, there's the EPA standard, and there are localizations of quite a number of things on the continent. There's the HL7, there's SNOMED, all of those standards in terms of data and digital health data. But more importantly is the fact that the public needs to have confidence in the fact that once they provide access to data, it will be used in the ethical way possible to actually provide them better value. So that is one key conversation that needs to happen. It's not just access to my data. If I know that if I give you access to my data, you will use it to be able to make my life better, there is a greater tendency that I will give you that data, right? So how do we begin to have that narrative of building trust in people relinquishing their data or giving access to their data? There's a conversation around data accuracy, quality, and completeness. Many times working in the field, you find out that data is not accurate. There's low quality data. The data is not, the quality of data is, low, beyond timeliness of access to the data. You find out that the quality of data is low, and it does not allow you to have a complete picture. So there is that part we need as a continent to begin to speak to the conversation around data accuracy. And one best thing, no better way to do this than and I use the example around data quality to speak to also data integration and resource limitation. The average primary healthcare worker on the continent, and let me use specifically Nigeria, actually fills about 13 registers, right? 13 registers, and I need you to take that in for a bit. 13 registers means the person is going to clerk. I did a research a while back, and I discovered that healthcare workers spend between 50 and 70% of their time actually writing, clerking, rather than delivering the care. So imagine, and there's also the preponderance or the assumption that if you put technology just directly into healthcare, will solve the problem. And the right answer coming from me, and it's something that you can take anywhere, the answer is no, it doesn't change it. And why doesn't it change it? Because first, you've not actually tweaked the process to be enabled by technology. You're still going to be having a paper, an hybrid kind of situation where the person still has to write paper and the person has to still do digital. So you're actually increasing the workload of the person, which is why adoption of EMRs has been slow on the continent. And also because from a data demand and use conversation, there's been limited demand from higher level up in terms of digital provided data. So for instance, director of pharmacy, if the director of pharmacy is still asking for regular report instead of actually looking at the dashboard on their desk or logging into their dashboard, you would have limited adoption of that technology process, regardless of how great the supply chain infrastructure you have put in place. So there needs to be that behavioral change conversation within the concept of technology adoption, which is also speaking to the fact of disease surveillance. Many disease surveillance people are technically sound in terms of the processes and procedures that were basically traditional. Now, the use of new technology brings new challenges of first building a behavior change component. So we need to build that behavior change component and allowing that different technology platforms that we use become more integrated. So, we can then look at how to mobilize resources around that. There's a conversation around algorithm bias, and that's a very clear thing where, because an algorithm has been programmed in a particular way, it might respond in that particular way, however, the question will be for us, and I will share a model around how to address this, where we can look at rather than a single source algorithm, then where we are looking at a multimodal algorithm that allows us multiple channels, multiple models before we actually triangulate and make a decision around it. So there's already a way around that. Then, of course, there's human expertise, which speaks to human capacity. There's regulatory and ethical frameworks. Government needs to move from being an enforcer to a facilitator of growth, the use of AI. So there's been significant issues with the adoption of technology, because policymakers usually have slower ways of responding in terms of policy to innovation. There's a big line in the innovation environment where we say policy catches up with innovation, which is very clear. However, the truth about it is that government or regulatory agencies need to become partners and facilitators of growth. Essentially, the continent needs to engage more. Then, of course, there's resource-intensive training that is required because AI, machine learning, and luckily, the continent has the power of the internet today. So there's so many young persons that are actually engaging around this. Of course, there's the adoption barrier we've talked about, and there's key in terms of how we begin to globally collaborate. The West significantly has built traction around it, and we'll see something around that shortly, where the West has built significant, literature around it. Ethical considerations, I've talked about this as well. But I'll just mention in terms of stakeholder accountability, beneficence and non-maleficence, which speaks to doing good and doing no harm, which is a critical aspect of medical practice, public health, and even just beyond the conversation around ethical good. And then there's continuous ethical assessment. The question will be, who will be accountable? How do we create accountability matrices around the use of AI in a situation like this? Remember, there's the conversation around overriding public interest. How do you manage the issue of abuse in case somebody is basically building certain things within the system or outside the system that you can basically manage to limit abuse of such system. I think because of time, the biggest things that we need to look at right now is, the road to the future for Africa is literally digital epidemiology. We need to constantly answer the question of how do we predict public health events before or as close to as occurrence as possible to reduce our costs. I talked earlier around, AI in public health research, and you will see this map. This is a nodal map that shows the kind of research that was being done and the kind of topics that people were looking at. And I'll show you a different map just right now. You see the difference in the growth of knowledge. So this is between 2003 and 2019, and this is between just 2 years, right? You see that there's significant growth in terms of conversations around public health, artificial intelligence, big data. And I'm happy to share this slide so that you can basically take time to look at it as well, to consider it better. So, for us, what is the future? The future already holds. We already have 5G. We already have Internet of Medical Things, Internet of Things. We already have precision medicine. We already have healthcare workers that have mobile devices. How do we empower them? How do we engage with the public to be able to understand that they are part of the public health infrastructure themselves, because the reporting of a public health event allows us to be able to see it? How do we build better early warning systems that enable us to give quicker responses? And one approach that I would like us to begin to consider, because this is both an academic thought process and expert conversation, is the holistic artificial intelligence in medicine approach that basically looks at integration of multimodal data, essentially, reducing bias, but more importantly, it gives a broad spectrum of data sets, a multiple loops for us to be able to remove as much bias as possible. So essentially, I am able to get inputs from as simple as all of my data sets, and then use multiple approaches within the AI framework and get real insightful data around a patient, their location, and public health events around it. This is something, from this conversation, I think Africa should begin to consider. And this is something in many of the conversations I've been having with, public health institutes and people within the disease surveillance space, even at the national level at the NCDC, where we can approach adapt this kind of approach. Another conversation is around the concept of clinical trials. Clinical trial, traditionally clinical trials don't really happen on the continent. It's quite limited. How do we then build more patient-centric approaches and be able to recruit better people, for clinical trials on the continent, so that we can build better evidences for it? Why are clinical trials very, important? It helps us to understand quite a number of enormous things, and we would not use the traditional approach that we're using. All right, there are quite a number of things that we already have that we can leverage on. There's our research data from Internet of Medical Things. There's our natural history data. There's biosensors. There's data from our EMR. There's our paper-based data, if you let me say that. There's behavioral science. So, how do we then begin to build better value for the continent in terms of this? And all of this would, I've been recently involved in the conversations around DNA sequencing, which is genomic sequencing. And one of the key things that, be able to see is that the more we understand the dynamics of disease and patterns, the better we are able to do it. So the more as a continent we do a lot of those, we are able to then build better value in terms of response to, we understand what can potentially happen. Other than building better responses, we can then begin to talk about, better precision approaches, to bring in medications and the likes. So it essentially reduces our cost totally. The road ahead, I said digital epidemiology. How do we then say we need to then bring that conversation around AI into our 717 approach? Maybe on the continent, can we begin to reduce the 7 to become slower? And subsume the 1 into becoming instant sort of processes. So then there's the aspect of us then investing in infrastructure. That is a no-brainer. We need to do that significantly, but not just infrastructure for infrastructure conversation. We're investing in infrastructure that allows, for us to be able to harness the power of recent technologies. So we're not just providing internet, but we are providing high-speed internet. That's very key. We're not just providing data centers, but we are providing data centers that can, manage a lot of conversations around AI, high-speed, high-powered data centers. And one key thing that is very important on the continent is, we train, we educate, we build awareness. That is just, probably for us, because we're a youth continent, we have the potential of building the competence of the continent, using AI, not just in disease surveillance, but across every sector, right? Just building that capacity of the continent and leveraging training and education is probably going to be a significant investment that, if we look at the examples of Singapore, if we look at the examples of China, if we look at the examples of India, before we even start going to those in the global north, we begin to see how, investment in education can significantly change the traction of, the immediate generation and the next generation. And of course, the ethical frameworks that we need to basically put in place. For me, I wouldn't want to go through all of this, AI and machine learning, or, the use of AI in, disease surveillance, is literally not just the way to go, but is the future that will happen whether we decide to move or not as a continent. We have the benefits of having global organizations that have done it. There are global countries, there are other countries that are moving in the direction of specific things, there are researches, and there are so many publications around the use of AI in healthcare, AI in supply chain, AI in, disease notification, AI in disease identification. As of today, I could tell you that your trackpad on your Apple phone can be used to diagnose if a person has Alzheimer's. That's how wearable technology or technology has significantly advanced. Your movement on the screen of your phone can be used to diagnose specific ailments that you have. And that's how technology has literally gone far. So the adoption of these processes allows us to, unbox what we call traditional approaches for healthcare, unbox traditional approaches that we call for epidemiology. And that's why, that integration, full adoption, full embedment of, digital epidemiology into what we call our routine epidemiology. In fact, we should not have a routine epidemiology process anymore. Our routine epidemiological process should be digital epidemiology. I think I have a quote from here before I open up for questions. We should not fail. Essentially, these two quotes are saying we should not be afraid to learn or to fail as a continent. But, regardless of the critics that may speak to us, regardless of the noise or the sound that may be, around us, but we should focus on our goal that we have set, and, definitely will not be underestimated. And critical thing is, whatever does not grow and change definitely dies. So if, just like you look at every circle of digital innovation across the world, or innovation across the world, Africa must not be on the back end where we are not able to fully harness both the power of our population and the power of our people. We can actually achieve significant growth as a continent. We can achieve significant traction as a continent. And, thank you for listening to me. And I open the floor for questions. Thank you very much.
All right, thank you very much, Abiola. Very insightful session we've had here today. I mean, you took us on a journey from a granular level, understanding, what the basics are required for us to be able to utilize AI within healthcare, and then gradually narrow it down to its utilization for disease epidemiology. You've given us practical examples of how this has been used across states to address and what the relative differences have been over time between year 2000 till date that has helped facilitate improvement in the use of artificial intelligence, but also what's different across states where AI was utilized against those that were not utilized in responding to disease outbreak. You've also talked to us about, some of the challenges with its utilization in Africa and given some proposals as to what we can do to address them. Very comprehensive session. Thank you once again, Abiola. There's just so much to learn or to have learned from this session. Quickly, we're going to be taking questions. If you do have questions, to ensure that we're maximizing the time, I encourage you to please use the chat box. There's a QA chat box on your screen. Just hover your cursor on the lower part of your screen. You'll see Q&A there. Please leave your questions there, and then we'll pick them up quickly for Abiola to respond to. We have some questions here already. From Deborah Okay. She said, can you give specific examples of AI apps that can do real-time data analysis and predictive modeling? Yeah, so this is an interactive session. We're going to allow Abiola respond to that question first, but we're also happy to get feedback from others on the call who would like to throw more insights. Feel free to use the chat box. Abiola, would you like to respond to that first?
Absolutely. So first off, let me start from the basics, right? So first is you first want to understand what do you want to do. So as of today, Microsoft and Google have infrastructure already built that has some data on it that you can then push in your data, and then it can help you crunch that data. So there's already that infrastructure in place. However, then that's significantly higher up the ladder. However, if you wanted to just do certain things around using just predictive analytics, right? I've used platforms like Power BI, based off of the data that I've crunched. I've used things like Zoho Analytics, to be able to help me first see insights of data. So first you need to understand, that question is kind of broad, and that's why I gave you spectrum from the lowest level. I want to see my data, and I want to see the pattern of my data, and I want to be able to use my data to predict based off of a time series. I will use Power BI, I will use, Zoho Analytics to be able to do that. Google Studio does that as well. But I want to go farther up into a lot of, deep learning. All of those features, competencies are already within, the Google AI infrastructure and the Microsoft AI infrastructure as well. So it depends on the spectrum of where you're working. So you need to kind of determine where you're working on the spectrum. And happy to hear other people's feedback with respect to that as well.
Right. Thank you very much for that, Sabiola. Is there anyone that would like to provide a response, additional feedback on that question? Please use the chat box so that we know. Jamal Jj, I can see your hand up. Could you use the chat bot to give us a sense of what you want to speak to? If you want to ask a question, and then we'll respond. We'll take it from there. Some clarifications. All right, Jamal. Please feel free to go ahead.
Hello. I'm very sorry to kind of request for this, but thank you very much, Abiola, for your presentation. It was a wonderful presentation. I'm actually a doctor, and I have a degree in clinical research as well, also a master's, ongoing master's in artificial intelligence. So I can say you covered a whole lot of it. But I'm just a little bit concerned with the application of AI that you mentioned, just a form of clarification, because I came here basically to have an idea of how AI has been applied in epidemiology. I've not done this kind of projects before. Now, for the project you mentioned of Ondo project, I just Googled it now and I looked at it. It's looking to me like a form of a case report, then observational study followed, then thanks to the EMR at that point, you're able to do some statistical analysis on it. So I wasn't sure where AI comes in specifically. And if it was an AI project, I was expecting the kind of model that was used, the accuracy and all those kind of stuff, but I couldn't find it there because I was trying to look at, okay, to have a further idea of how epidemiology projects are being presented in AI, but I couldn't get that. If you can make some clarification. And lastly, is that of course AI is very just like a general comment. AI is very good, and in the nearest future is going to do some amazing thing, but it's not like it's going to give us a one-time solution to what you're actually looking for. The aspect of moving hand to diagnose tremor and maybe also using some Internet of Things to diagnose medical condition is far from what we can achieve now. Is extremely far because the data out there is highly inaccurate and we can't use just one particular features to actually make some diagnosis. I just want to make comments on that. There are some documentation on that, but the medical community or the AI world in general will not accept that we are going to move into that anytime soon. But please, can you clarify on the project you mentioned? That's my question. Thank you.
Thank you very much, Jamal. And let me start from your second question and just refer to that. Now, you remember that I'd actually introduced a model, two models to you. And I talked about the conversation around random. Those two images I introduced were basically one around changing conversation around research, specifically to be able to improve the integration of better value for AI and better positioning for AI. The second one, which is the iceberg model I showed you second. And the first one was the HIAM model, which I was basically speaking to the concept of you needed to essentially bring multiple data sets, right? From the beginning of the conversation, one of the things I have maintained critically is that the best way for you to be able to get significant value from AI is to unlock your different data silos that already exist, pull them together, build your data lake, and use that data lake to be able to significantly use the different algorithms that you've built, whether a time series, whether predictive analytics, to be able to understand what exactly is going on, right? So the first thing first is, just speaking to that specifically is, I do not, and I cannot recommend a single source of truth, specifically because even as a human being, you have fundamental data that you are interacting with in multiple terms, right? You have the environment, you have your consumption in terms of your nutrition, you have your genetics, you have quite significant aspects of all of those data sets. What I'm fundamentally positioning is, once I am able to recognize all of the data sets and I put them together, it helps me define who you are. It helps me be able to understand certain things about you and then use that data to make decisions about you, right? So essentially, precision medicine will be better treatment plans that are customized to you because then I have better data sets around you, right? And that's exactly where I'm going to. Because what I'm saying is that we are collecting data, we're collecting so much amount of data at different points of different people's lives, but those data don't speak to one another. How do we then begin to build the infrastructure that allows us to interoperate, which is where the conversation of interoperability comes in, interoperate data to be able to then make those decisions leveraging AI. Now, going back to the Ondo case, right? One of the very first things the Ondo case tries to do, because AI at that point was extremely not a slang, it was more of a machine learning conversation during that period. And we already had conversations basically using the AI process in the back end. So first, I basically first described something you would elementarily call clinical decision support, right? But essentially, the clinical decision support was embedded based off of specific data sets that we had collected over a a longitudinal period of time, which is where the EMR conversation. So at that point, based off of trends of conversation, and which is why when I showed you the map of, and I wish I showed you the map of how people are writing about AI on the continent and how people are writing about AI outside the continent, you would have seen the disparity. So what we basically tried to really focus on when publications were going out was what was more acceptable within the public domain, or what was more acceptable within the domain of what, you know, activities were. So we focus more of speaking about the EMR, you know, observational processes like you rightly talked about. But underneath those processes, essentially, was essentially the AI framework that actually did the actual work, you know, that we built upon, because it was difficult for us to have been able to, first of all, identify specifically that we were dealing with a particular disease type, or with a particular outbreak type. If we had waited for the approach that would have been the normal approach, or, you know, unsupported approach with what we did, that's one. Then the second part was the fact that after the approach was even done, the response that we used was guided based off of specific data sets and prediction capacities that were already built into the system fundamentally. So for us, we were more focused, and, you know, because I led that process, I was literally more focused around ensuring that the real conversations kind of focused on what was permissible, what was allowable within the public domain at that time, you know, in terms of languaging. So if I use the example of, if I spoke about AI in 2015 within the you know, public health domain in Nigeria, I will be speaking like I was speaking from the clouds. That's exactly what you are saying. So 5 years later, it may look like it's easy to speak about it, but it was going to be difficult for me to be telling the governor or the commissioner that will be providing support from them with AI and machine learning. I would literally have to go into a lecture of explaining all of those things. And you would have seen all the authors, all the papers that were authored had people with representation, either at national government, state government. So you would have seen that, you know, these were guided or teleguided based off of the prevailing understanding and knowledge of the people that were working there. So it, you know, it was literally out of scope for them. So, you know, and that's one of the big things around public policy, public health security, where I was talking about policy catches up with innovation. So essentially, if that was, I can tell you, they would have shut the process down immediately if I had mentioned that this was going to be fully computer driven, rather than, you know, assisting the process. So that's exactly my response to your question. And I'm happy to have this conversation a lot more for me to provide more clarity to you on that. Thank you.
All right, thank you very much, Abiola, for that very detailed response. And thank you, Jamal JJ, for contributing to the conversations. I hope you got the clarity that you need. Just to add to that, I think Abiola, we've quite advanced beyond the period where you had written that research or the publication you spoke about. I guess it may be worth a conversation worth having to see how can we communicate in more detail what implementation approaches we had carried out at that time, and maybe do a comparison to what is obtainable now. But I think, you know, just to solve the sort of questions that Jamal may have for other participants or for other people of interest in the future, it'd be important to also tell the story from the perspective of technology. Just something to think about for the future, you know, adding to the body of knowledge. But yes, once again, Abiola, thank you so much. I believe you did justice to this session. We couldn't have had a more interesting or better session. Thank you so much for that. I would like to just take 1 minute pause again to ask if anyone has any questions. I want to believe there are no further questions. If there are no further questions, and I want to seize this opportunity once again to thank Abiola for sharing with us from his depth of knowledge It has been a very insightful session. I have particularly learned a lot from this session. I've seen, a number of people on comment section talking about the work that they do. And, there are obvious opportunities for us to continue to converse about what we're talking about here today. We encourage interactions with stakeholders and members on the call. Please feel free to reach out to Abiola should you have questions and comments. I've also seen a lot of questions regarding the recording and the slides. We'll try to make those available via our platforms. If you're not currently a member yet, you can look through the chats. We've left the link on how to join the AD network. In addition to that, you can follow us on our LinkedIn page, and we will provide updates on both the videos and the slides once they become available. We'll probably need to do a bit of edits here and there before we share them out. So just keep an eye on this space. We'll make the documents available as soon as they're finalized. Having said that, thank you all very much for sparing the time to join us today, for staying true from the beginning till now. We look forward to having some more insightful and engaging sessions in the coming months, especially as it relates to artificial intelligence. You can hold me accountable to that. Thanks a lot, everyone, and do enjoy the rest of your day.